appreciate this invitation to speak to you today, and I'm looking forward to updating you on some of the recent happenings in the world of alopecia areata. It's certainly a very exciting time in the world for alopecia areata research, and the pace of research and knowledge is moving forward at a speed that was not present before. And so it's really an exciting time, and I'm glad to be able to share this with you today. Now, you're all familiar with alopecia areata. Alopecia areata really has many different types. And so some patients develop just one patch of hair loss. Some people develop several patches. Some people develop total hair loss. There's really a lot of different kinds of alopecia areata. And about 2% of the world overall is affected by alopecia areata, so it's pretty common. There are a lot of treatments. I think the last time I added them and counted them up, there was about 30. And probably in the clinic, we use or talk about easily 20 of them. And over a longer period of time, easily 25 of them. And so there really are a lot of treatments. And what comes as a surprise to many people is that none of them are FDA approved. None of them are Health Canada approved. So everything we use in the clinic, from steroid injections to cortisones to diphencyprone to you name it, they're what we call off-label. It means they're approved for something else, and we borrow them into the alopecia clinic to use them. So that's called off-label. And so we don't yet have an FDA approved and Health Canada treatment, but that will change in the years ahead, no doubt about it, when some treatments actually get formally approved, increasingly recognized, and then they'll be increasingly covered by many insurance plans. And so that's really the goal, is to formally approve many of these treatments that have benefits. There are an enormous number of treatments, and without any hesitation, we use all the treatments on this list at some point. Now, the most common treatments are steroid injections and topical steroids and diphencyprone and prednisone and some immunosuppressants. But every one of these treatments is used. And so there really is an enormous number of these treatments. We don't yet have a cure. We have treatments that help some people, but they don't help everybody. And so that's really the goal, is to get treatments that are more consistently effective, especially for more advanced forms of alopecia areata, like alopecia totalis and universalis, and patients with more significant amounts of hair loss on the scalp. And so who's working on the answer? Well, I'm happy to tell you that there's a lot of people working on the answer now. This is a graph of publications in the medical journals from 1864 up until today. And what you can see is that every year it's increasing. Every year there's more and more information being put out on alopecia areata, and this is translating into better and better treatments that are coming our way. So it really is an exciting time in the alopecia areata research world, and this intense research effort and all these publications is going to translate into better treatments in the very near future. So when we look back at 1891, some researchers in France identified that, aha, there is inflammation under the scalp around hairs. Researchers at the time didn't really know what to make of this, but it was the first indication that inflammation might have something to do with this condition. But in the 1890s, all the way up to the mid-1950s, the concept of an autoimmune disease of any part of the body didn't exist. And so it really wasn't until the 1950s and 1960s that physicians and the medical community started talking about autoimmunity, meaning the body's own immune system can target itself. And so this is where there became an increasing recognition that maybe alopecia areata is an autoimmune disease. And sure enough, that is what it was ultimately discovered to be, that the body's immune system is activated and it's targeting the hair. So let's take a look at what an autoimmune disease is when we refer to the hair follicle. So this is the skin. This is a cartoon that I'm going to describe now. This is the skin layer. And underneath the skin, we have hair follicles. This is an orange colored hair follicle. So this would be from someone who has orange colored hair. And what happens in alopecia areata is there's inflammation that develops around the hair follicle. And that inflammation causes the hair to fall out. And if we can get rid of that inflammation with various treatments, we can cause the inflammation to disappear, and we can cause the hair to start growing back. And so this is a type of condition where the hair loss is not permanent. It can be challenging sometimes to get it to grow back, but it's not permanent. The information is there in the scalp to grow hairs. We just have to find the right way to get it to grow back. And so for the last 100 years or more, we've been in an era of what I call non-specific treatments. So we have these treatments that just tell the immune system to settle down, but they tell all of the immune system to settle down. And these are what we call non-specific treatments. And steroids, steroid injections, cortisones, methotrexate, other treatments, cyclosporin, these are all non-specific treatments. They tell all of the immune system to settle down. So if a patient with alopecia areata starts prednisone and they have eczema or rashes on the body, they may find that they get a bit of hair growth, and they may find that their rashes settle down. It's targeting many parts of the immune system. It's very non-specific. But the whole new era that is waiting for us is this specific era, and it has now started. And what the specific era is treatments that target a very specific pathway in the immune system that tell only part of the immune system to settle down. In other words, the part of the immune system that's responsible for the alopecia areata. And so specific treatments are those which target just a part of the immune system. You may have heard about the JAK inhibitors, tofacitinib, ruxolitinib. If you've never heard of these, that's okay. We're going to talk about them today because these are specific treatments that target just part of the immune system. And there's many, many others in clinical trials, probably about 10 to 15 of them that researchers around the world are studying. And the hope is that if we target just part of the immune system, that we might get treatments that are safer because we're not telling all of the immune system to settle down. And we might have treatments that are potentially more effective because we're specifically telling the interaction between the hair follicle and the immune system to change. And so these are what we mean by specific treatments. We're going to come back to this, but let's review just for a minute why people develop alopecia areata in the first place. Well, people are born with the chances to develop alopecia areata. And many of my patients are surprised to hear that. But the research has shown us time in and time out, time again, that the genes that cause a person to have alopecia are in them from the day they were born. But some people develop it and some people don't, even if they have the genes, even if they have the information in their genetics. And the reason seems to be is because the environment is very important. The world we live in influences whether you develop it or not. And so studies have shown that even with identical twins, if one twin develops alopecia areata, the chances that the other twin might develop it at some point in their lives is not 100%. It's only 50%. And so we know that things in the environment play an important role as well. And we don't understand all of this yet, but these are things like stress, like infections, like diet. And this is an area of very active research trying to figure out if someone's born with the chances to develop it, why does it happen? And how can we alter this in some way so that even though a person is born with the chance to develop it, they never develop it? So research is underway. And so if genes are so important, what genes are important? Well, for many years, we didn't really know what genes were important, but the last few years have been in a very exciting period where the genes for alopecia areata have been better and better understood. And this really took a turn in 2010. So just 10 years ago, some remarkable studies were done by Angela Cristiano and her colleagues at Columbia University. And I call this the 2010 Alopecia Areata Gene Study. And what Dr. Cristiano did was she studied 1,054 patients with alopecia areata and compared the genes to 3,278 people who don't have alopecia areata. And she asked, what's the difference between these two groups? What genetics do people with alopecia areata have that people that don't have alopecia areata don't have? So this was a remarkable study, a very complex study. And what she found is that there's 8 really, really important genetic differences in a person's genetics that influences whether they're going to develop alopecia areata. And this was incredibly remarkable. And she followed up these studies a few years later showing that maybe we can extend this from 8 to say that there's about 16. But there's a defined number of genes that are involved in alopecia areata. But there was a really, really important surprise that came from all this. And this surprise has revolutionized alopecia areata from that day forward. And let me tell you what that was. For years, it was thought that alopecia areata was closely related to psoriasis. It was thought that they were sort of like cousins. They're both inflammation conditions, some immune-based condition. But the problem is that a lot of the treatments for psoriasis didn't seem to really help alopecia areata all that consistently. And so Dr. Cristiano's 2010 study showed that, alopecia areata is actually much more closely related to type 1 diabetes and rheumatoid arthritis. These are the close links. And so then researchers began to ask the question, if it's so closely related, can we use drugs that are used for rheumatoid arthritis to treat alopecia areata? It sounds far-fetched, but it actually turned out to be true. And so tofacitinib is a medication which was approved for rheumatoid arthritis around that time in 2012. And researchers started asking around that time, including a group at Yale University, my colleague Dr. King and Dr. Craiglow, can we use this tofacitinib rheumatoid arthritis drug to treat alopecia areata? And the answer was yes, it worked. And this led to a massive increase in studies on these drugs, which are called the JAK inhibitors. So the JAK inhibitors are specific treatments. They shut down a part of the immune system called the JAK pathway. And I'll just explain that very briefly. So here's our hair follicle, and we have inflammation around the hair follicle. And let's magnify this even further. So here we have the hair cell, and here we have the immune cell. And let's look at what's happening in alopecia areata. Well, it seems to be in alopecia areata that the hair cells make a lot of a chemical called interleukin-15 or IL-15. And this tells the immune system cells to increase a message inside those cells called the JAK pathway or the Janus kinase pathway. It's like inside that immune cell, someone shouting, activate the JAK pathway, activate the JAK pathway. And the immune cell then makes a chemical called interferon. And that activates a pathway in the hair cell called the JAK pathway as well. And when the JAK pathway is activated in hair cells, the hair cells makes even more interleukin-15. And when it's more interleukin-15 around, the immune cell makes even more interferon gamma. And so we have this dynamic going on where we have inflammation developing. And so the JAK inhibitors, when a patient takes them, shuts this down. It shuts down the JAK pathway, and the inflammation disappears and the hair has a chance to grow again. And so we've got many JAK inhibitors that are already approved. They're already sitting in the pharmacy shelves. We have tofacitinib for rheumatoid arthritis. We have ruxolitinib, which was approved in 2011 for a type of bone cancer. We have baricitinib, which was approved for rheumatoid arthritis back in 2018. So we already have these medications. We can borrow them for some patients to treat alopecia areata. They're not yet approved, so they're still in the study phase, but we can use them sometimes off-label. And there's been 30 publications in the medical journals with 289 patients so far, but many thousands studied around the world, showing that about half of patients with pretty advanced alopecia areata can get improvement. And so they can be very helpful for many patients. Here's an example of a patient on tofacitinib with alopecia, advanced alopecia, either totalis or universalis, getting significant regrowth of hair. And so these are really the next stage in these specific treatments. And there's lots of JAK inhibitors in clinical trials. Many people on the Zoom call today may be familiar with Concert Pharmaceuticals' clinical trial of CTP 543. Pfizer has 2 drugs that are in clinical trial stage as well. So lots of JAK inhibitors being studied at the present time. And there's many other pathways that researchers are studying besides the JAK pathway to figure out how can we calm down the inflammation that's developing. So you'll be hearing a lot more about that in the future as well. So what else have researchers been up to? Well, they've been up to a lot. You can tell from this graph that it's a busy time. Up until 2015, we had quite a few treatments, but from 2005 to 2020, we've had even more, and our list is getting even bigger. Researchers are interested in a cholesterol medication called simvastatin. This is a medication which many of you are familiar with for high cholesterol. Some studies have shown that it can help some patients with alopecia areata, maybe about 20% of them, so not everyone, but still a very unique application of a cholesterol medication that can affect inflammation by reducing inflammation. There's research into platelet-rich plasma treatments, which is a treatment where you take your blood, spin it down in a fancy machine, and you inject your own blood into the scalp. Researchers are looking at topical JAK inhibitors instead of the pill forms to see if these can help alopecia areata. They're not as effective as the pills, but they may help some people. Many of you are familiar with minoxidil topically that you get over the counter from the drugstore. Researchers are now increasingly looking at minoxidil pills, which have been around for about 35 years. Researchers have been studying vitamin D, and 2018 was the year of vitamin D for alopecia areata, where a number of studies sent the same message to the world, and that is that many patients with alopecia areata have low vitamin D, and the more significant the amount of alopecia you have, the more likely you are to have low vitamin D. So there's clearly a link between alopecia areata and low vitamin D. We just don't understand it all yet. And it's not so simple as taking vitamin D pills to help hair grow. It's more complicated than that, it seems, but nevertheless, an area of future direction. Finally, researchers have been studying gut health, or the so-called microbiome. And researchers in many parts of medicine are interested in understanding what lives in our gut and how do these bacteria and organisms help us and how do they hinder us. And so the gut microbiome has been an area of intense research in understanding how having a healthy gut can help your immune system function properly. And more importantly, how can having an abnormal gut or an abnormal microbiome lead to immune dysfunction, or what they call dysbiosis. So many patients will ask me, do you think I have dysbiosis? And they're asking me about their gut health. Well, how do we have a good, healthy gut? Well, we don't know yet, but it seems that eating the right foods helps having a healthy gut. Lots of vegetables, lots of fermented foods, low sugars, reducing stress, sleeping more, not smoking, limiting antibiotics that kill the good bacteria. These all promote good gut health. But there's one other fascinating way to have good gut health, and that is by taking the fecal material from someone who has a healthy gut and putting it into the bowel of someone who doesn't have a healthy gut. And for those of you who have never heard about a transplant, that's essentially what it is purified fecal material from a healthy person is put into the gut of someone who is unhealthy. Does gut health have anything to do with alopecia areata? Well, it certainly does. This is an absolutely fascinating study from 2017. This was a patient who had alopecia areata on the left, and they were admitted to hospital because of a gut infection. They had a serious infection called Clostridium difficile, which can be life-threatening, very serious. And in order to help this patient overcome their gut problems and get them out of the hospital, a fecal transplant was performed where someone's feces, who is healthy, was transferred into the gut of this patient. This patient's gut improved, their Clostridium difficile improved, and they left the hospital, and essentially their life was saved, but what was discovered is their alopecia areata went away. And so it's really a remarkable study which has set a whole new direction for the alopecia areata world in understanding just how important our gut health is in alopecia areata. So tremendously exciting study. So what are the directions for the future, and what might I have the privilege of updating you at some point in the future? Well, the race is on to really use this genetic information to someday determine who will develop alopecia areata and who will not. To predict if someone will develop a patch of alopecia areata, or are they more likely to develop totalis or universalis? Can we prevent this in the first place? Can we predict what treatments will work? Should we just wait for one person to see if their hair will grow back spontaneously? Or for the other person in the next room, should we give them steroid injections? And for the person in the room 2 doors down, should we start them on tofacitinib? And so those are questions that will be answered. What truly is the best treatment for patients? And is it possible someday to give a treatment that's short-term, that you take a treatment for a month or 2 or 3, you reset the immune system in some way, and then the patient is unlikely to develop alopecia areata in the future? And so these are really exciting questions that lie ahead. But that's where I will end. I want to thank you again and all of CaNAAF for this invitation to speak. And I'm looking forward to answering the questions that now await.